Welcome to the Deep Six podcast, where we make a generational impact on you and yours. What we do here is explore a 6-point model into your health, your life, and your journey while you're here. So let's dive deep and help you thrive, not just survive. Well, welcome again here to the Deep Six podcast. I am Dr. Lewerenz, the Chief Medical Officer of Longevity Health Institute, as you know, and the host, obviously, of this podcast, and have a wonderful guest today. Actually, super excited because known each other a long time, and I highly respect him, and does wonderful things in the community and with my personal patients and all over the country. And I'll let him explore all that. But is Dr. Joel Kahn, who is a cardiologist from Michigan here, but he's known as America's healthy heart doctor, big supporter and promoter of heart health with a vegan and plant-based diet. And anyway, Joel, welcome. Appreciate you.
I am fired up. I know we're 2 buildings apart in one of our locations, and I got to bump into you usually in Florida or Las Vegas at an integrative conference. So here we're doing it.
Yeah.
We had a cup of coffee in the same room, but it's good to be here.
Maybe one day we'll be in the same office, because, as the world and life evolve,
Right.
But hey, man, I appreciate you. We got a lot of mutual patients. By the way, before I start, I want to say Happy Mother's Day to your mom.
Thank you. That's one of them. She's my mutual mother and your patient, and thank you for taking good care of her. And yes, thank you. Happy Mother's Day.
And the funny thing is, in the studio next door, I got my mom teed up for the next episode for Mother's Day. She's 84. And
Right.
And proud of her health journey in the last 20 years or so. So we're lucky to both have great moms and actually have them still here, I think.
I agree. Wish her well.
Yeah. So, you know my model and all that, and for the audience, just how we look at basically 6 major points, of hormones and gut health and nutrients and, functionalities of, physiology in the body. But on my podcast before, many times, probably not once, is I always say stuff like, you don't get out of here without coronary artery disease, and, to dig into that a little bit, what I mean is, and I've heard this phrase, but we're all going to potentially die with some form of coronary artery disease. We just don't want to die from it. And you're the expert in that. So How awesome to have you.
It's a big problem. And for reasons I don't completely understand, the public hears, and I think the medical community, much more about brain health, gut health, longevity, metabolic, dysmetabolic syndromes and all. Heart health is like an orphan child, and it obviously shouldn't be based on the statistics. I'll just tell you, it's not just my opinion. When I lecture to the public, I just lectured today for them, I show this slide that when people Google causes of death, 2% of the searches in an entire year, so we're talking, hundreds of millions, if not billions of searches, actually are on heart disease death. 98% are on terrorism and motorcycle accidents. And when the New York Times and the English premier paper called The Guardian report on death in America and England, 2% of the time it's on heart disease, but about 31% of us die of heart disease. So there's this real disconnect that I'm a rock star at integrated meetings because I'm a cardiologist, and it's rare, and it shouldn't be. I mean,
Right.
We're talking about heart disease. We need to talk about heart disease, and it fits in your model, of course, because everything you work on, impacts the health of the heart without a question.
To me, and this is a thing, and that we see is, of course, people come in and want an actionable to feel better. They want to have energy. They want to, lose weight. They want to, and they don't usually come in to any doctor, I don't think, ever, not, and say, or any primary care or any functional medicine and say, I really just don't want to die of heart disease, or I really don't, want to have a heart attack. That might be way down the list, but usually there's some other thing they want. And what I have to often do, and my practitioners do, is we always have to loop back to that, like, hey, listen, all this other stuff's not going to matter. unless we really, pay attention to and screen, which we'll get into, heart disease. And, it's the leading cause of death, like you said, but it's very underappreciated. And I think very preventable, right? Very, very preventable.
Right. Yeah. Just for your audience, just to remind them, I just gave a lecture to a big women's group last night, but I lecture all the time. In the whole world, every 1.7 seconds, somebody dies of heart disease. If you just shrink it down to the United States, every 34 seconds, somebody dies of heart disease. Of course, some are old. 20% of these deaths are people under age 65, totally tragic. Every 40 seconds, somebody has a heart attack in the United States. And this is with all the technology we have available, that 1,000 people a day, this is the one that tears my heart apart, die of something called sudden cardiac death or cardiac arrest. You open the bathroom door and there's your husband blue on the floor, dead, pulseless, and the chance of resuscitating him are, way under 10% to hospital discharge. Tragic. That's 1,000 people a day die suddenly without warning, unexpected in the United States alone. And just one more. This is the most, to me, amazing statistic that gets me riled up. I'm writing a new book called A War on Heart Attacks because I think we don't have one and we need one. But from 1775 to currently, there are 650,000 American soldiers have died in combat. Tragic, honor their memory. 900,000 plus people a year die of heart disease in the United States in 1 year. And, you just look at the conversations. Yeah, we sort of have Heart Month, but really we only go red for Women Friday, and then we forget about it. 365, 24/7. We're doing it right now. We got to be thinking about this silent killer. It's the problem. I wish heart disease caused acne or wrinkles because we'd go do something about it. But
it's funny you say that because once I know a patient, a female, and whatever is going on and, we're fixing and working on, I joke and I'll always say there's two things women don't want, and even men, but, is like, they don't want acne or skin conditions and they don't want wrinkles. And if you want to put the cherry on top, it's losing hair. They don't bring up the heart stuff.
66 years old. I'm hanging on to mine.
Yeah. Well, listen, I mean, so I'm thrilled that you got a new book coming out because, I love the book, but also I love the title, and you have others, which you please mention, but the dead execs don't get bonuses. I still think about that often and go, that's perfect because for whatever reason, not that it's, I try, but I end up seeing a lot of entrepreneurial businessmen, hard driving, CEOs, et cetera, I'm sure as well as you. And they're living so, I call it hot, with all this adrenal, imbalance in their, sympathetic, parasympathetic tone. And I have to, you'd be surprised. I have to make them either, get a test or really take it serious for heart disease. And they're one of the biggest risks.
Yeah, the only guys that go for heart testing are guys that have erectile dysfunction. And I tell them, you're not getting the prescription for the blue or yellow pill till you go get your heart testing. And they go get their testing. And of course, if just in case anybody listening isn't aware, there's a very well-described relationship between men with erectile dysfunction having silent unknown heart disease, the canary in the coal mine. So we obviously test every woman needs to be tested. But if there's ED involved, I've got them by the neck. I'm not helping them till they get tested.
Yeah, good. Yeah, good. Well, and you probably can recall the study, but I know it was like 15, 20 years ago. There was a study when Viagra and all that was kind of, coming into popularity and et cetera. And there was a pretty strong association in a study, wasn't there, to erectile dysfunction and coronary artery disease?
Multiple studies leading to, I think there's been 3 of them. They're called the Princeton Conference on Erectile Dysfunction, that, it's urologists and vascular people and cardiologists and lipidologists. The conclusion is, my conclusion is, work every man up around age 45 for heart disease, but certainly any man with erectile dysfunction. Not as simple to pick those women out. I say for women at menopause, if you haven't had a heart workup at menopause, that's your erectile dysfunction kind of line that I'm pretty insistent. But yeah, it's been known for years. And I don't see an internal medicine or family doctor in the city demanding the same discipline. No drugs for your ED till you get your heart checked. They should.
I love it. I love it. Yeah, and that's super important. Saving lives and making a big difference.
Right.
So since we're on this, how do you? I mean, there's a lot of cutting edge things, and there's a lot of new technology, and cardiology is advancing so fast, and I would love to dig into that. But just what is your approach when somebody's a male's 45 or a woman's postmenopausal in the early screening or detection? What should we be doing?
Yeah. Knowing that we get about 8 seconds of attention on social media, hopefully a few more minutes on a medical podcast like this. The quick answer is get a $100 coronary artery calcium score.
Love it.
I really get worked up and rant on this, that we being the medical community, family doctor, internist, we see somebody age 45 to 50, write the script for the colonoscopy, the mammogram, get the PSA, do a pap smear, and they walk out of the office, nothing's done to check the heart. The only conclusion is there isn't a screening test for the heart, because you're not going to accuse your doctor of being heartless and not caring about your cardiac future. And that is wrong, because in 1990, the University of California, San Francisco developed a special CT scanner that could show. This isn't going to show well. You just lie down in a scanner. It takes 5 seconds. And you get images of the heart since 1990 that show if your arteries are without or heavily calcified. So it's called a coronary calcium score or coronary calcium scan. And since 1990, and in our Michigan, the first machine arrived here in 1995. So 30 years. There's 10,000 research studies. The price has gone from $1,500 down to about $100. The radiation exposure was never high, but it's gone down based on better CT scans. And there's clear evidence that if you're a 0 score or you're a 100 score or a 400 score or a 1,000 score based on this test, it's hugely different 10-year prognosis. You're still likely to be alive and do okay. But you're getting to the point that if your score is high, you're about 25% likely to have a major event. In fact, in the last 12 months, there was a paper published, Doc, I feel fine. I go golfing, pickleball. I go to, Equinox and Lifetime. Nothing wrong with me. If your score is over 300, you've got the same 10-year prognosis as somebody who's already had a heart attack. And had a heart attack. I'm wonderful. I feel great. No, you're not. You got old heart, old arteries. So, and you could argue, and I wish Bobby Kennedy Jr. did argue, just pay for this damn test. The state of Texas, they'll pay for it. No place else will they pay for it.
Oh, really? Texas does.
If the test is 0, you probably don't need a whole big workup. Just repeat it in 5-6 years. If it comes back 200, 300, 400, then you need all the labs and all the hormones and all the toxicity testing and the whole gamut. So you can triage people immediately. And even a score of 1 or 4 or 5 at a young age, at age 45, that's disease. Can't ignore it.
Yeah. And something that's recently been published and talked about in social media and everything, but is which was actually profound to me because I think of and read the journals and all that stuff about the glycocalyx and the endothelium and all that stuff, but how they found this in autopsies of teenagers, that there was already endothelial, damage that young. So as a teenager. So when people say, oh, I'm too young for that. Well, shit, don't forget out there, everybody. People have heart attacks in their 30s and 40s.
We're not doing too many CT scans on teenagers, but
no.
Teenagers should eat well. Teenagers should work out. Teenagers should know their blood pressure. Teenagers should try and avoid obesity, which has tragically not happened very well. And teenagers probably benefit from some decent labs like a cholesterol panel. 1 out of every 250 teenager has a hereditary cholesterol disorder called HeFH, and you might have a cholesterol 300-400. You might want to know that. And my big, subspecialty, this is another book I wrote, is the cholesterol that you inherit from mom or dad. 25% of people can make two cholesterols, regular cholesterol and this genetic cholesterol, lipoprotein little a. I would like to know in every 18-year-old, I would tell and I see these people in my clinic, the
Yeah.
parents bring their kids. I would like to tell the 18-year-old, you're going to live a long life. I'm not going to scare them. But you probably ought to eat a salad once in a while, have an apple, go to the gym,
Yeah.
don't smoke.
Yeah.
And then when you get a little older, we'll check you. So there's always going to be those advanced labs. But if we just did the calcium score, now, in my clinic, we do a fancy carotid scan,
Yeah.
the carotid IMT scan, but that's actually a very hard test to get around the country. Got a patient in Dallas. Where do I get one? Well, I call a few companies. It's not so easy. The CT scan, universally available.
Yeah, very available. Yeah, and I find, and you pretty much taught me this, and through the years is you can pair that, with the risk stratification with all the labs, and the deep dive into the labs. So maybe you can mention if you found some calcified arteries, or you had a score, even if it was 50 or 100 or whatever, what would be maybe some of the labs or things that you might look into? That obviously you already mentioned one already, the LP little a. What else might you do?
I just had cases study in the last 10 days. Two guys, they're business partners in the cannabis industry in Michigan, big industry. They're 45 years old. They look pretty similar. They're not cousins, but they're both built. They go to the gym. They eat pretty clean Mediterranean, Lebanese, Chaldean kind of diet. They're not smoker, even though they're in the cannabis business. They're not smokers. And as a lark, they both went for a calcium scan. One guy came back 0, pretty happy guy. Yeah. And one guy came back 598, which for a 45-year-old is 99 percentile.
Yeah.
And of course, I did do some labs on the guy 0. He was in my clinic. The guy with the 598, we're going to do every kind of insulin resistance testing. So I need him fasting to get hemoglobin A1C and fasting insulin and C-peptide and calculate his insulin resistance score or his HOMA score or something. We're going to do every inflammation marker in the book. Lately, the one I've added is cystatin C, which is a kidney marker, but there was a really powerful paper in the last 12 months. It's a big time cardiac. I see a lot more people with subtle kidney dysfunction as tested by cystatin C than I do by UN and creatinine, and that's actually been reported. We're going to do, all the lipid numbers, the regular panel, the particle size and particle number, and of course, lipoprotein little a, homocysteine methylation pathways. I get some genes. Most of these guys like this one, I'll get ApoE, MTHFR. I don't go real deep on that, but I go. And then there is an obscure gene called 9p21. And in various studies, it's actually the most common abnormal inherited gene that promotes cardiovascular disease. There's not much you can do about it other than healthy lifestyle, but a lot of people want to know, why do I have this high calcium score?
Right.
Omega-3, vitamin D. I'll do heavy metal testing. You do it better than me, but I'll do some. Lately, I've been doing the Vibrant panel in selected people for environmental toxins. If they want to pay the money, it's not covered by insurance. I mean, we can measure your glyphosate and your BPA and BPS and, ask the question, who the hell is poisoning you? Is it your food?
or like the arsenic I got when I got back from Florida from the sea. I learned that one.
Yeah.
I told my wife she wasn't doing a good job.
Yeah. We say in my clinic, if we're not drawing 15 tubes of blood, we're amateurs.
Yeah.
And what a lot of people are doing too, and you see it in your clinic, they're spending $500 and they're getting the functionhealth.com 102 tests. Yeah. I'm not a super fan of that, but frankly, so many people are identifying that they've got an elevated lipoprotein A or elevated cholesterol or elevated homocysteine. They're coming to see doctors like you and me once they have that test. So it's actually caused my phone call to ring more because of this kind of very popular. And let me just say the last thing. I don't want to interrupt you, Jim.
No, please.
I mentioned the simple CT scan. I don't think 5% of men and women in the United States are having a coronary artery calcium score. There is a better test, And it's been around since 2010, but it really got juiced up in 2020. It's a coronary CT angiogram. You put an IV in, you go to the CT machine, lie down, but you get iodine, so you can't be allergic to iodine. You feel hot for 20 seconds, take the IV out, Band-Aid, go home. So the test takes a few more minutes. It is a little more radiation. But by the addition of the iodine, now you really see the whole artery. Now you get a report that says this spot's 20% narrow, this spot's 50% narrow, this spot's soft plaque, this spot's hard plaque. And then the AI company called Clearly, Cleery, can analyze that with a precision. I'm a former cath lab guy. We never in the cath lab could tell a patient you're 72% blocked and it's mainly soft plaque. We don't have that technology. And these things are revolutionizing cardiology. The problem is it's sort of run by radiology. So cardiologists are resisting it. There's no money in it for them. Right. No money in it for me. I don't own a CT scanner. They'd rather do a nuclear stress test, which is a radiation bomb. They'd rather do a catheterization, of course, which is inherently much more risky than this CT. So a lot of people are paying up to $1,500 to have the ultimate definitive test. So the guy with the calcium score of 598, I told him, I don't know how blocked you are. I don't know how much soft plaque. Soft plaque's more dangerous. He's going next week and he's going to get the primo package and he's going to pay for it. But if you got a cancer diagnosis, you get PET scans, MRIs, you get all kinds of things. Heart disease, you get a calcium score and we stop. But I don't stop. I push out.
And I have a story just this week, literally, of what exactly you're saying. And it was unfortunately a business guy that literally, like I said, when these guys run hot, I would had a high superstition or premonition, if you will, looking at his labs and numbers, which, by the way, I didn't have to be that smart on this one. It was very low-lying fruit because he smokes cigars, he's overweight, he has some insulin resistance, but he's resistant to doing tests. Well, his calcium score, off the top of my head, it was like, I think about 400. And I just said, listen, we got to get a CT angiogram on you, or you got to go to a cardiologist, and I give him options and all that stuff. And he was, what he said to me, which is funny. He's like, well, I'd rather get a CT in my chest because of smoking. And he goes, I think I might have lung cancer. And I go, you probably don't, but oh, by the way, he's 50.
Yeah.
And so I got the angiogram, which you'll be seeing him. I don't know how much he'll listen, by the way, because he's a little stubborn. He's set in his ways a bit. But anyway, long story short is he has a 80% or greater right coronary artery lesion. Yep. So, he's going to cath lab, like you said.
The interesting comment you made is, if they get the calcium score, there is a lung report. And I have diagnosed lung cancer and I've diagnosed lymphoma. And a lot of times I'm diagnosing aortic aneurysm of the thoracic aorta.
Yeah. Yep.
So it's all scary news for patients, but it's also very important news. And if you get the more advanced test, you also get that result. So, we got to be careful with radiation. There just was a report last week made, I think it was in JAMA, 5% of all cancers in America may be due to medical imaging. So I don't repeat these CT scans very often, but boy, that initial one is, is really eye-opening.
Yeah, and I think if you could comment on this, because I think there's pretty close to about 15% in a study that I read. But the tradition, right, is, we'll get a stress test on you, on a lot of these people, and treadmill, and maybe an echo with it. And isn't it something close to like 15% of people pass that and have a heart attack within 5 years?
Well, it's 15 to 20% of people come back with a normal stress test and they have advanced disease. So there's major problems with the accuracy. You never see the arteries, so it's all indirect information. And, cardiologists, and I was one, blame me. We love the nuclear stress test. It's the highest reimbursement, quote, maybe it's 1% more accurate. It's a radiation bomb. That's why these CT scans are more accurate, less expensive, and less radiation. So it's just a power play over who controls the fiefdom.
Yeah, definitely. Well, other than, the big stuff, that's obvious, meaning, weight loss, smoking, poor lifestyles, diabetics, insulin resistance, fatty liver, some of these that are going to put you at risk.
Right.
What are the things that I know you're a big vegan, plant-based supporter. You'd be proud of my smoothie this morning, by the way, a lot of greens. But my point is, like, what are the interventions you often use in these people in a clinical setting?
Yeah, I ask them all to, we're living in a world where carnivore, keto, paleo, and bashing on seed oils is like the official government policy. A little distressing. Even seed oils. I mean, the problem is they're in junk food, and it's the junk food. It's not
that we
just,
love,
but that we love. It's frying French fries in beef tallow does not make a French fry healthy. Sorry. If nothing else, advanced glycation end products you're creating, but you shouldn't eat fried food. Period. You'd be far down the road. So anyway, so I let them know there's data out there, that there's a guy named Dean Ornish and a guy named Caldwell Esselstyn. I ask them to watch Forks Over Knives, if they want to read one of my books. I present the science data. Maybe 40% of the patients in my practice adopt a largely or completely plant-based diet. And it's such a hoot. Doc, I'm a vegan now and I eat eggs and cheese and turkey. Okay, but I'm not passing. You're not my vegan. I mean, having been a vegan now for 48 years personally. And
by the way, I got to interrupt you. Yeah. I miss your restaurant. Just so you know, I love that restaurant. Your food there was amazing. Loved it.
I eat in town. I just eat at regular restaurants. I'm careful. So beyond diet and obviously fitness, and we do a ton of home sleep studies and diagnose sleep apnea and try to improve their sleep and, teach them some stress reduction or throw them on ashwagandha or do something, get them to quit smoking. There's a great book called Alan Carr's Quit Smoking Now book. I didn't know about that. It's an old book and it's really helping people make some progress there. There's not many smokers left, but there are. There's supplements. There's some nice data from UCLA that aged garlic tablets called Keolic actually reduce soft plaque. There's actually clinical data. I like a life extension product called Arterial Protect. It's pycnogenol and gotu kola, but there's studies out of Italy that it reduces plaque, human studies. Okay. There just actually is a study this week that Ficitin, that in strawberry, they prevent arterial calcification. It was a basic science study. We need a little bit more, but it's such a cheap supplement. Yeah. A lot of people are taking it for anti-aging anyways.
I love that you said the Gaolic, which is our garlic, supplement. I personally take that because I've seen some stuff just clinically, but there's a study on it. So that you said that's a reduction in soft plaque.
Yeah, it was a UCLA study, very nice study, and actually surrounded by other human studies of benefits. Lowers blood pressure, lowers homocysteine, lowers lipids. So I use statins only in people with established cardiovascular disease. I take people off statins if they come back with a calcium score of 0 and they have nice clean carotids. I mean, so many women at age 50 are on a statin. They don't have any disease. And, I work with them with other things. But I've just lately been using the term microdose statins, like people talk about microdose GLP-1s. My typical is 2.5 or 5 of rosuvastatin, Crestor, with ezetimibe, Zetia, a perfect combination we've known about for 20 years. But about 3 years ago, a big study in Korea, and just 6 weeks ago, a big Mayo Clinic Proceedings publication that basically said we could save hundreds of thousands of lives a year in the United States alone if doctors would just routinely prescribe this 2-drug combination versus a high dose of just a statin. So I keep the statin dose crazy low, and I probably give the biggest doses of CoQ10 in the world, 800 milligrams a day, 1,000 milligrams a day. You can go on Amazon and buy a 1,000 milligram CoQ10 capsule. It's actually ubiquinol, so it's a super powerful liposomal CoQ10.
It's as big as your pinky? It's got to be pretty big.
Yeah, it's a suppository. So, so I see myalgia and I see brain fog. I definitely see statin-related blood sugar elevation. Grieves me a lot. Yes, and I'm the last human on the planet. I still use a lot of extended release niacin. And it's like almost illegal to talk about that with general cardiology. Niacin is about the only thing right now that lowers lipoprotein little a. And it also lowers regular cholesterol and LDL cholesterol and triglycerides. In the 1970s, all cardiologists loved niacin. Statins came along, and it kind of, 20 cents a day to take 500 milligrams twice a day. But anybody listening, talk to your doctor before you go.
Of course. Yeah, talk to your doctor. But can you mention about how they take niacin? Can you mention?
You take 500 milligrams with breakfast, 500 milligrams with dinner. Watch for a little flushing. I don't do the aspirin applesauce. Okay. I've tried immediate release niacin, which is how it was used in the 70s and 60s and 80s. And it's a trip. I mean, whoa. I mean, but there's a brand. I mean, I don't own it. It's called Enduracin. That's extended release niacin. And that's what almost all of us left in the world. Most of us are people concentrating on treating lipoprotein little a are using Enduracin. Yeah.
Gotcha. Good.
And we need better tools. There's new drugs coming out in the next few years for this because there is no drug right now.
Right.
FDA
will you see like a PCSK9 inhibitor like reduce LP little a at all?
Yeah. So I wish PCSK9 inhibitors are a drug you inject every 2 weeks. One brand Repatha, one brand Praluent. FDA approved to lower cholesterol and improve outcome. But they do drop lipoprotein A about 25, 30%.
Oh, okay.
And SEAM, another big paper published this week, like 300,000 participants, suggestion that they're improving outcome in lipoprotein A patients. But they're $800 a month, and the insurance company fights you like a dog. I wish they were generic. So I have people on them, but we get rejections all the time. In insurance. They want the patient on a statin. They want documentation that the Lipitor caused severe myalgia. And so, you could falsify the patient's records. I prefer not to do that. Or you just tell the patient you can pay for it, which most don't want to do. It's too bad there's no generic for those for about another 3 years, I think.
Yeah.
They're good drugs. They're good drugs. I mean, I don't think any drug is a great drug, but they're good drugs.
Yeah. Is there any external, I read some stuff, it's not my field, so I'm kind of like, but is there any external, meaning things that can be performed, if you will, to help somebody's heart disease? Like we know lifestyle stuff like weight loss and exercise and reduce your insulin, that. But is there any, good evidence about
reasonable data, infrared sauna?
Oh, okay. That's what I was getting to.
In Japan, infrared sauna is really like a class 1 indication for heart disease. And it's underutilized for heart disease, for heart failure in Japan, for angina, for peripheral vascular disease. Even these old, frail people with bad disease they'll heat up the infrared sauna, they'll wrap them in towels, put them in there for 15 minutes, take them out, hydrate them, and let them cool off for half an hour. And it's called Waon therapy in Japan, WAON.
Yeah. Okay.
There's something called EECP. You're probably familiar with it. The squeezy trousers that in the 80s and 90s got FDA approval for bad angina pain. Yeah. And it still works. I actually had the first machine in the state of Michigan in 1995, I think. And we used it a lot in my private practice in Troy at the time. And then the hospitals got it. We sold our machine. Now it's hard to find. I'm not sure if Corewell still has a program.
I've seen it. There's a few people I know using it, but not.
Dr. Dan Govian had machines, but I don't think he has them anymore. Jim Roberts had machines. I'm not sure he has them anymore, but it still works for the. It's usually your last line therapy, but in LA, people are going and getting these squeezy trouser treatments just for kind of a wellness.
So essentially what they are for the audience is it's kind of almost like a big long sock all the way up to your waist to your pelvis and their compression basically, and they do it rhythmically, I believe. I'm not that I've had it done. I've just watched.
It's timed to your EKG. You're gonna squeeze during diastole to get more blood flow to the coronary.
Yeah, so it's putting pressure essentially back to the heart.
That's about it. There's no cold plunge data. Red light therapy probably is good for cardiovascular health. I mean, there's not a lot of data. I'm a fan, but there's not a lot of data. Mm-hmm. Can't think of much else. Obviously, stents and bypass as the last resort.
Yeah. Is there so I gotta ask you this because I think we've talked about this, but it's such a a fad. It's such a in vogue right now. Drives me
Right.
crazy, by the way, because I have patients ask me still all the time, and it started a few years ago. But I know you've seen people on the carnivore diet. I'm
Right.
not an advocate of this. I just want to get your input on this and what you've seen because I believe you've seen some pretty drastic things.
Yeah, I see some people, and they really have the most bizarre labs. I mean, most of them do have pretty high total cholesterol, LDLs 350, LDLs 250, a fair amount of inflammation, like no vitamin C, which you'd expect. You're eating meat.
Yeah.
There's essentially no,
No vitamin C.
and they don't seem to be developing scurvy. And I haven't seen anybody explain why they're not developing scurvy with no vitamin C in their diet. Unless they're supplementing, which would be smart to do if you're on a carnivore diet. Now, just real quick, I don't want to take
Yeah.
up too much more time and we'll close it out. In the last 3 weeks, there's been an enormous controversy because a paper was published called the Keto CT study. 100 men who were chronically doing the ketogenic diet and they were lean. They had a BMI under 21. These were thin people, not real bulky, muscular Sean Baker, MD people. And they drove their cholesterol up to 350, 400, 450. The average LDL was 250 in this group. And they had a baseline, clearly CT angiogram, and a year later went back for a second one. And the data was published by Dave Feldman. You might know he's not a doctor, he's an engineer. There was one very prominent UCLA cardiologist involved in the publication. He's a world famous CT expert. And the headlines initially were high LDL cholesterol had no correlation with plaque and a real attack on the whole cholesterol hypothesis.
Mhm.
Immediately, people that really were good at reading literature said, you said you were going to study how much change there was over the year in their soft plaque. You didn't even report it in the study. When you registered the study, you didn't report it. And it looks like people were actually getting worse over the year. You didn't talk about that.
Yeah.
It has blown up in Twitter, Facebook, YouTube,
Oh,
everywhere.
okay.
And there has subsequently been a letter to the editor published and a response published in the last 48 hours. And most reasonable people are saying it's just stupid to eat a keto or carnivore diet without checking your cholesterol, because not everybody, but a good number of people just rocket their numbers up. And now
Yeah.
we've actually got data. They didn't die. It's only 100 people for 1 year. It does look like their plaque accelerated much faster than expected for a group of that age and that fitness and that
Yeah.
leanness.
And it
So-
would make sense too, because it's the opposite of, a vegan, diet or a plant-based diet, essentially, where you see, those diets interventions reduce cholesterol and reduce, all the coronary events and coronary disease.
There are smokers that don't get lung cancer, and there's people with high
Yeah.
cholesterol that don't get obvious heart disease early in life. But all you can do with most of this stuff is, play the odds and
Yeah.
bank your chances you're going to stay healthy in your 60s, 70s, 80s, and 90s. Right?
Yeah. Well, I want to take just a couple more minutes if you can, just because you brought it up. So I'm going to
okay.
bring it about
Okay.
what is your experience the last 5 years? Because I have my opinions and I think we're pretty aligned here. And I know there's science on this, on, what COVID has done, what the, spike protein has done, what the vaccine has done.
Yeah.
And from a cardiovascular sense, because I've never drawn, by the way, more fibrinogen and D-dimers in my life.
Yeah. So, my own, if you would have asked me in 2019, how much you know about vaccines, how much you remember from med
Oh,
school, how many
yeah.
books have you read, what's in your waiting room, it would have been pretty close to zero. I also would say, when's the last time you had a vaccine? And I would have told you a long time ago. I wasn't even getting the flu vaccine. I didn't really want it. I never had a problem. You're supposed to for hospital provisioning, but there's always a workaround. And then I got COVID in late 2020. My daughter's wedding had to be canceled. And I started reading about the vaccines weren't out yet. Started reading about natural immunity. There already were a lot of people publishing on natural immunity, publishing about vitamin protocols like vitamin D and zinc and quercetin and NAC. And I love supplements like you love supplements. And these were, what I was impressed, these are like big academic doctors, chairmen of the Department of Critical Care Medicine publishing that this might help people. Then, of course, we started to hear about hydroxychloroquine and a little later ivermectin. I just became skeptical early on. As it turns out, I think, I just had a sense it was right. So my wife and I, we didn't get vaccinated, pissed off the entire family, my elderly mother. I mean, everybody was on our case. And we did fine, and and all that. And I actually advised my patients to get vaccinated in early 2021, but stuff kept coming out. So, I am not a fan of the childhood vaccine schedule. I like something called the friendly vaccine schedule that some pediatricians have, and very few in Detroit will honor, but there's a few. I have grandkids now, so I care a lot more about this topic. But I won't say I've got a specialty clinic. I don't have an ICU clinic. I've not seen a lot of myocarditis. What I've seen a lot of is persistent, and 23-year-olds, persistent brain fog. I got palpitations. My heart rate's running 90, 95 all the time, never used to. I don't have the exercise tolerance I used to have. I stand up, I get dizzy. A couple actually are like POTS, postural-orthostatic tachycardia syndrome. Maybe one or two pericarditis cases. And they all pretty much, after working up everything else, seem to have post-COVID. You always got to be careful. Do you know it's the vaccine, or did they have the COVID illness and some long COVID persistence? But I continue to see that, and it shocks me 3-4 years after their last COVID episode or vaccine. There is both LabQuest and LabCorp and Quest have I was told it was a spike protein level, but it's actually an antibody to the spike protein level. And it should be by now low. And these people that don't feel good, they're coming back sky high. Mm-hmm. What do you treat them with? Nattokinase and do you put them on some ivermectin? We're all kind of struggling. What's the best way to do with it? But it's a real deal. I'm not seeing turbo cancer. I'm probably not the right clinic to be seeing turbo cancer. Yeah. Obviously, that's a term.
I've just seen like that. I've noticed since all that, and obviously in 2021, 22, and when we knew stuff about the hypercoagulability and stuff that I was drawing a lot more D-dimers and a lot more fibrinogens. But if you put the risk stratification, like closing the loop here of what we're talking about is heart disease, I just noticed that people were getting some vascular things that were really odd. I'd never see. I had a couple young guys getting DVTs. I had some people like that their calcium scores actually got way worse within a couple of years. It's like we couldn't really put it together. So could be anecdotal, but I just, it's something that I still look at.
No, there's good literature out there now. I mean, I gave a public talk, as I mentioned last night, to a group of women, and actually somebody asked Q&A about vaccines and COVID, and I could tell it was, to be honest, and I gave the same response I just gave you. And a woman came up to me after. She goes, 1 week after my vaccine, I had a stroke, and they didn't believe it could be related. And I've never found a doctor who talks openly that it could be. This stuff happens all over the place.
Yeah, absolutely. Well, Joel, hey, listen, America's healthy heart doctor. I appreciate you. My patients appreciate you. And,
neighbor from a distance, thanks for taking care of Mama Kahn. Appreciate it.
And Mama Kahn, she's, by the way, a pleasure. When I see her on my schedule, I just get. I'm not joking. I'm not saying this because I value that someone's been here that long, that happy, and also, that healthy, but also kind of motivated to be alive. And she's a joy. But
a woman that's been on hormone replacement therapy for about 35 years.
Yep.
And got the brain of a 30-year-old. I mean, she's sharp as a tack.
Yeah, amen. And I'm glad you brought that up and endorsed that because that's my 84-year-old mom. She's been on about 20-some years, and it's made a huge difference in her brain and brain health and overall quality of life. But keep doing your good work and motivating us all and keep us on the cutting edge of all the knowledge. Thank you.
Okay, test not guess. Don't walk around, you people listening, without getting your heart test, please.
Well, thank you again for joining me here and Dr. Kahn here on the Deep Six podcast, where we dig deep into even coronary artery disease and interventions to help you thrive and not survive. Be well.